Good afternoon and welcome to the next presentation in the Hackensack Meridian Health Women's Wellness Webinar Series. It's a brief introduction. I'm Dr. Michael Del Rosario. Even in my practice, I like to spend some time with patients finding out a little bit more about them and more than just why they're in the office, which is usually a serious problem. A little bit about myself. I was born and raised on Long Island. Somehow survived public high school, attended Vassar College in Poughkeepsie, New York. Used to be an old women's school. I studied chemistry there. After that, I attended medical school at the State University of New York, Downstate College of Medicine in Brooklyn, New York. My general surgery residency was at the Robert Wood Johnson Barnabas Healthcare System. I finished as chief resident. And after that, I pursued specialized training in colorectal surgery and underwent fellowship at the University of Illinois, which is the home of the Fighting Illini. I am a double board certified surgeon in general and colorectal surgery. Some of my proudest accomplishments include being the first surgeon in South Jersey to offer patients minimally invasive colon surgery, first laparoscopic, and now robotic surgery with the Da Vinci system, which is an integral part of the Hackensack Meridian Health care system operating rooms. Other than that, I've been serving the South Jersey community continuously for over 20 years. Again, I thank you for allowing me to speak today to you on the topic of colorectal cancer screening. Hopefully you can see my screen there, my slides. I'm going to make this topic very basic. It doesn't need to be complicated. I find that often patients come into the office with a lot of information, which they're uncertain of. And the best way to deal with this is to simplify the topic. There's no need for overly detailed statistics or percentages. What you need to take away from today is if colorectal cancer screening is right for you and what your choices are. There are 5 subtopics we will talk about today. The importance of screenings or why we're doing this. Topics 2, 3, and 4. The types of screening, frequency, and choosing the right test we will lump together. And then the last topic is the age to start screening. Also, please feel free to ask questions in the chat box. I can answer as we go along or at the end of the discussion. Okay, so let's move on. Let's start out by discussing first of all, what is colon cancer? Here's a little bit of anatomy. Again, very basic. This is the human body. Here's your stomach. Here are some small intestines. And this is the large intestine. This is the colon. There's about 6 feet of this. The colon has cells which are in what's called the mucosa. They constantly grow and shed just like your hair or just like your fingernails. Colon cancer can occur when the cell growth starts to become unregulated or grow out of control. It can be a problem. It's really a problem of the genes, but not necessarily in the sense that this is a genetic or hereditary problem. Most cases of colon cancer are actually sporadic, 60% or so in patients who have no family history whatsoever. So if you look over here, this is the colon polyp to cancer sequence. So people, you don't just wake up with colon cancer one day. It starts very small as a little growth. It could be the size of a grain of sand. And it can, over time, over years, it can progress to the size of a pea or a marble. These are the types of lesions or growths we may find in the colon. And over here, these are all benign. So these are polyps. But if you look over here, there is a change. And this is what's called dysplasia. It's still benign. It's a precancerous polyp. And then there comes a point at some time when the growth or the benign polyp becomes malignant. And at this point, it's cancer. The word cancer actually comes from the Greek word meaning crab. And, if you are in New Jersey, we're very familiar with the blue claw crab. You think about what a crab looks like. It's got spiculated shells, it's very jagged, and what do crabs do? They burrow down into the mud. So here's cancer becoming invasive. So whereas here, these early polyps are just kind of staying in place here, the cancer over here is starting to grow. And this is all happening here in the anywhere in the 6 feet, that's your colon. So, next slide. Who gets colon cancer? Statistically, there are about 142,000 cases combined with men and women. And because this is a women's wellness webinar series, we're going to focus on the women's aspect of it. Of the 142,000 new cases per year, about 67,000 new cases are those in women. So it's about half. So colon cancer affects men and women equally. Let's look at this graph over here. Excuse me there. Right there. This graph shows the types of cancers, new cases in women only. Number 1 is breast cancer. Number 2 is lung cancer. And number 3 is colon cancer. So amongst women, colon cancer is the third most common type of cancer they can get. And if you think about, breast cancer here being so common, there was a time many years ago when the topic of breast cancer was almost taboo to talk about it. Women were embarrassed or uncomfortable talking about it. That has since changed because the numbers are out showing how many women it affects. The topic of breast cancer nowadays has become a topic of dinner conversation or a simple friends to friends conversation. It's something I hope to achieve also for colon cancer, that we can openly and freely talk about it. Let's go on to the next slide here. So who dies from colon cancer? Again, let's take men and women together. There are about 53,000 deaths per year. This is from 2022, of which, again, almost half or just about half are women. In this graph, the types of cancers that women die from, number 1 is lung cancer. Breast cancer is number 2, and colon sits there at number 3. All right, let's go further. So it does occur, and it leads to deaths in women to a significant amount. So why is screening so important? So the last 2 slides, we saw how common colon cancer is and how many people it affects and kills. When that becomes an issue, we have a cancer or disease that affects so many people and could be preventable, we would seek to screen for that disease or cancer with the goal to improve life, the quality of life, as well as healthcare costs. To use a common saying, literally screening is the ounce of prevention versus the pound of cure, which is surgery, or which can be surgery, chemotherapy, radiation, time away from life, and then life itself. And this is why screening is important, because we want to stay over here on this side. Okay, so let's move on. As I said, I'd like to group points 2, 3, and 4 together. And these are, we're going to talk about the types of screening tests, the frequency of screenings, and choosing the right test. There's a lot of different types of tests out there, and these are the ones that are approved by the Centers for Disease Control. And these are the only ones you really should be choosing in terms of screening for yourself. So types of screening tests we can break down to stool type tests, which is the fecal occult blood test or the fecal immunochemical test. There are radiology tests such as the CAT scan or virtual colonoscopy. There are also endoscopy tests, which is the flexible sigmoidoscopy and the colonoscopy. Okay, stool tests. So FOBT, or fecal blood test, it's a test you can do at home. You're given a card and you put a smear of stool on it, and it uses chemicals to detect blood in your stool, much like you might test your pool water for chlorine. It turns a different color if there's something bad in there, or turns another color if it's not too bad. Can tell you a positive or negative. Fecal immunochemical tests is a little bit of an advancement over the FOBT. It uses immunohistochemical studies to look for antibodies in addition to the blood in your stool. This is a card, or is a container. It is done at home, but it's sent out to a lab for evaluation. The theory behind the FIT DNA testing is that if you have a polyp or a cancer, as I said earlier, the cell is growing out of control, so the DNA in that cell is altered and abnormal, and that's what this test is looking for, abnormal DNA, which may be shed by polyps or cancers within your colon. The FIT tests and the FIT DNA test may be anywhere from 75 to 92% sensitive, meaning the chances of it picking up something abnormal. Let's talk about advantages and disadvantages of the two. The nice thing about the stool tests, do it at home in the privacy of your own home. You don't require anesthesia. There's no need for the bowel prep or taking medicine to help you or to give you a lot of diarrhea. It shouldn't be invasive. If it's invasive, you're doing something wrong. You don't need to put the card up there. You take a piece or smear of stool and place it on the card. It's also covered by insurance. So those are nice things about the stool tests. The disadvantages are it does need to be repeated frequently. This is in part to the lower sensitivity or the detection rate. It may miss some polyps, it may miss polyps, it may miss cancers, meaning you do the test, it comes out good, you feel good about yourself, but there is a bit of risk that you may miss some polyps or cancers. And on the flip side, it may also have false positives. Sometimes the result of this test is affected by medications you're on, or diet you're taking, or bleeding from hemorrhoids, for example, so you may get a false positive. Other disadvantages, okay, if it is positive, you still have to do something about it, because this test just tells you that there may be something wrong, but we're not quite sure what it is. Okay. The next option is a radiographic test, or it's a test done by radiology, and we're very familiar with CAT scans. Here you are going into a CAT scanner, and the images generated from a virtual colonoscopy or CT colonography kind of look like this. This is maybe the mucosa of your colon, and this is a growth. You get radiographic pictures of the colon from the virtual colonoscopy. Well, that seems nice. She seems very happy here and she's smiling. But what are the advantages? It's nice. The CAT scan, you don't need anesthesia. It is less invasive than other procedures. Why do I say less invasive? You still, they still need to put contrast via a tube that goes up into the rectum to help give us a good picture. So there is some degree of invasiveness of this procedure. It's also nice. It may be covered by insurance. Advantages are, again, if this virtual colonoscopy shows something like a polyp or a growth, it may need further workup. Now, I'll go over this. I have this on both advantage and disadvantage. Disadvantages of the virtual colonoscopy: needs to be repeated more frequently than other procedures, every 5 years. It still may miss polyps or cancers. If the polyp is flat or if it's very small, it may not be seen on imaging. And on the other side of that, again, you may have false positive. If you're, again, you do have to take a prep. So if your prep is not good, it may not give you a good picture. And in the disadvantage column is that the virtual CAT scan still requires a bowel prep, which actually tends to be the item most patients complain about. It's the bowel prep. There is a low-dose radiation. It also may not be covered by insurance. And if the CAT scan, the virtual CAT scan shows something, it's going to require further workup. The reason I have it, this, if positive, requires further workup as both an advantage and disadvantages. I think in the future it'd be nice if we could have this CAT scan to help us decide who needs to go further in terms of getting a colonoscopy, which is an endoscopic invasive procedure. Maybe if the virtual CAT scan is negative, you wouldn't need to go further to have the invasive procedure, which would be the colonoscopy. So it can work both ways, a virtual CAT scan. Alrighty, let's talk here. The third type of screening, approved screening test is in the category of endoscopy. This would be a flexible sigmoidoscopy or the colonoscopy. The flexible, here's an end-over image of the colonoscope. It's about the thickness of your pinky or your finger. There's a camera lens, there's a light, there's a hole or a port here to blow air to help distend your colon. There's also a channel here for us to put instruments into. Flexible sigmoidoscopy is basically 1/3 of a colonoscopy. Remember I said we have about 6 feet of colon here. The flexible sigmoidoscopy is looking at the bottom third of your colon. The colonoscopy, look at the full 6 feet. Way back, this is a picture of Katie Couric. Many of you may have watched the Today Show way back in 1997. Her husband was diagnosed with advanced colon cancer. He subsequently passed away several months later. As part of, she was, from her experiences dealing with colon cancer, Katie was motivated to increase awareness about colon cancer and the importance of screenings. She actually underwent her first colonoscopy on live TV, awake, without any sedation, and she got screened on the Today Show. As a result of her efforts, it was found that the screening rates had gone up about 20% because of increased public awareness. Back to endoscopy, some of the advantages are it's diagnostic. Whereas with the whereas with the stool tests and the CAT scan, that just tells you, well, there may or may not be something there. The endoscopy tells you you have a polyp or you don't, or you have a cancer or you don't. It's also can be therapeutic. If you have your endoscopy and you see a polyp, many of these polyps can be removed through the colonoscope, and that, in essence, is the ounce of prevention. That's a cure right there, because you're preventing that polyp from growing into a cancer. Because it's very accurate, very sensitive, and therapeutic, the colonoscopy can be repeated less often. You don't need to get this every year. You don't need to get this every 5 years. It really can be anywhere from 7 to 10 years if you have no other risk factors, for example. But the message here is, whereas the stool test you have to do more frequently because they're less sensitive, and same with the CAT scan, the colonoscopy does not need to be done as often, and it is covered by insurance. Some of the disadvantages are it is an invasive procedure. It does require anesthesia and a bowel prep. With invasive procedures, there are risks. There are very low risks, such as bleeding or perforation, but the risks are outweighed by the benefits of the colonoscopy, which is the screening and detection of polyps and colon cancer. You can still miss polyps. They're very small. The colon is a very twisty organ. There are little folds in the colon. They can hide. Colon polyps can hide behind folds. Some of this comes down to your anatomy and the skill of the endoscopist. The miss rate is very low. So those are the 3 basic types of screening tests that you can consider. So we talked about stool tests, we talked about radiology tests, and we talked about endoscopy tests. Choosing the right test. What's right for you? What you choose depends on multiple variables, including your age, your overall health, access to what doctors, what's your family risk, other past history. You can't apply what one other person has done for themselves to you. You are your own person. These are the right things here. Talk to your healthcare provider. Don't talk to Dr. Google. I can't tell you how many sad stories of patients who have come in with an advanced colon cancer, which has gotten to that point because I read on the internet, this is what you're supposed to do. You can use the internet as a guide for sure, but nothing can replace speaking to your healthcare provider in person, where they can look at your history, your family history, your overall condition, and decide which of these tests is appropriate for you. So that would be choosing the right test. Okay. Age to start. So when do we start? Like, when do you get your colonoscopy? This is a common question patients have in the office. When do you get your first screening test? Here's a graph of the rate of new colon cancers by age. So as you see here, as we get older, here's 85 plus, as we get older, this rate's going up. Let's focus on this area right around here, 40 to 44, 45 to 49. And just kind of remember this area right here. And if I was to break up age, let's talk about average risk, and let's talk about increased risk individuals, that is for developing polyps or colon cancer, and then let's talk about plus or minus symptoms. Okay. Is this you? This is a picture of Olympic female athlete. You might be a vegetarian. Maybe you've never smoked in your life. Maybe you don't drink. Maybe you have no family history. You're in great shape. You're young. This is still the average risk individual. If this is you, you need your colonoscopy still by virtue of age at 45 years old. Flip side of spinning this is it's a misconception that if you're young, healthy, don't eat meat, don't drink, no family history, you don't need a colonoscopy. Let's go back a bit there. That's not true. Ooh, sorry about that. There we go. So Here, just by virtue of turning 45, you could be this person. When you turn 45, you need your first colonoscopy. Just by age alone, not knowing anything about you, 45. This is average risk. Okay. And then we move into increased risk. It's a family tree. Some items that may cause you as an individual to be at increased risk, maybe there's a family history of colon cancer, colon polyps. Maybe your father had polyps, maybe your mother had polyps or colon cancer, maybe your brother or sister had polyps. If you do have family history of this, then you are at increased risk. Remember, it's not necessarily a genetic problem by inheritance. It is a gene problem in that the genes of the colon cells, get out of control. But it can also be inherited to a degree that if there is a family history, this may prompt you to have your colonoscopy screening at an earlier age. Let's say, for example, your father was diagnosed with colon cancer at the age of 53. The general recommendation is you should get your colonoscopy 10 years earlier than the age of diagnosis of the affected family member. So you would theoretically get your colonoscopy at 43 instead of 45 if you were average risk. Again, this is kind of fuzzy math, but these are topics you need to discuss with your healthcare provider, and they'll sit down with you and identify all the risk factors you have and make an educated recommendation as to what age to start screening based on your risk factors. So that's family history. Other risk factors include inflammatory bowel disease such as Crohn's disease or ulcerative colitis. If you have any of these conditions, these may confer an increased risk of developing colon polyps or colon cancers in you. You may have your screenings much younger than 45, for example. So that's increased risk. Okay. The last subtopic of when to start screening. I can tell you this was sent to me from a previous patient of mine many years ago. A young lady walked into my office with her father. She was 38 years old and pregnant. And I walked into the room and I said, "Oh, very happy to see you, Mr. So-and-so." I thought he was coming in for an office visit as I'd operated on him for a rectal cancer. And his daughter was with him, pregnant. And it turns out she was the patient. She was 38 years young. At the end of her first trimester, and she had developed some rectal bleeding. So what does Google tell you? Rectal bleeding in a pregnant patient, likely due to hemorrhoids, correct? Well, she was very educated and informed. She was very smart, and she talked to a physician. She went to her physician and said, I'm pregnant, but I'm having some rectal bleeding. Her primary care then referred her to a gastroenterologist who listened to her problems and performed a flexible sigmoidoscopy, and they found the colon cancer at 38 years old while pregnant. Colon cancer in pregnancy or in pregnant women, there's about a 0.008% chance of this happening. Sadly, we are seeing this increase a little bit for a couple of reasons. Women are having children at later ages, and we're also seeing colon cancer in a younger patient population. So I was very surprised to see her as a patient, but we waited a little bit. She passed into her second trimester, We performed a minimally invasive surgery on her and removed the colon cancer, all while the little baby was in the uterus. She recovered nicely from the surgery. The final pathology showed that it had already spread to the lymph nodes, and this brave woman underwent chemotherapy while pregnant, all pregnant, and she came to full term and developed a healthy girl, and her name was Autumn Hope, but she, this picture is actually a year old, so she just turned 9, so we're 9 years after treatment of colon cancer in a pregnant lady. She wouldn't be here today if she didn't go to her doctor and let her physician know that something was wrong, and if her physician didn't listen to her and refer her for the appropriate workup. So symptoms is the important part. At any age, if you have symptoms, it's something to discuss with your healthcare provider. And I'm going to spend a little bit of time here on some of the common symptoms we see in colon cancer. Colon cancer. For example, bowel habits change. You know, for many years, you're regular, like clockwork every other day, every day, and something changed. It doesn't mean that because you had an off day or a bad day of bowels that you jump and go get a colonoscopy or talk to your doctor. If there's something bad going on in your colon, it's not going to go away. If this is something transient or temporary, maybe you ate some bad food or you're traveling or your schedule's off, it's going to resolve and go back to your baseline. But if you do have a change in bowel habits and you don't tell anybody, you know, there could be something wrong and it needs further investigation. I tell people I'm a plumber. Your colon is just a set of plumbing. If the plumbing gets narrowed, your bowels may change, either in size, shape, or frequency, just like regular kitchen sink can get backed up and overflow. The same thing is happening with colon cancers. As they grow, they could be narrowing their plumbing. So, you know, talk to your provider and describe what's happening. Don't just self-treat or get laxatives and try to push the symptoms away. You should talk about it. A change in the color of your stool may indicate blood, which may come from a polyp or cancer. Really, by the time your stool has changed color, the growth is usually quite advanced. The previously talked about fecal occult blood test or the FIT test. You don't see blood in your stool based on these tests. These tests are detecting blood and DNA at the microscopic level. But if you grossly see a change in your stool, you should talk to your provider. Same with rectal bleeding. Not all rectal bleeding is hemorrhoids, and not all rectal bleeding is a cancer, but it's something you should raise as a symptom with your healthcare provider. Any other vague symptoms, such as crampy abdominal pain, that's just not going away. These may be signs that there is a problem in the colon. Previously mentioned difficulty with moving your bowels, fullness as well. These are symptoms that you may have just in your belly. Other more subtle symptoms that they present with colon cancer are fatigue, because colon cancers, as they grow, they tend to bleed slowly and you become anemic, leading to fatigue or tiredness. The cancer grows and it consumes your resources and it can sap your energy. It also puts you in a catabolic state. So instead of what you eat like your proteins and stuff going towards maintaining muscle mass and strength, you start losing weight because the colon cancer takes us over. So these are some of the more common symptoms you might see with colon polyps or cancers, prompting you to get screened no matter what your age, whether you're 45, 40, 35, or younger, if you have some of these symptoms, it's something to discuss with your healthcare provider and see if screening is right for you. And again, on the flip side, from the earlier slide with the Olympic athletes, just because you have none of these doesn't mean you can't have a colon polyp cancer. By virtue of age, you get your first colonoscopy at 45. Okay, let's see here. I think we are. Oh, okay. So I've changed the topic to yes, colon cancer screening is right for you. My only message to you is be educated, be aware, and speak with your healthcare provider of the types of tests I discussed with you. I mean, whichever screening method you choose is the best method, as long as you do something to get yourself screened and potentially avoid the pound of cure. Do something to help better health and prolong your life. Screening is something that should be done, and it is really the ounce of prevention versus the pound of cure. I think that wraps it up for me.
Great. Thank you so much.
You're welcome.
Thanks everybody for joining. If you do have any questions, you can put them in the Q&A chat at the bottom. We do have a couple of questions, so I will read those now.
Yes.
So
I can see it. Do you want me to answer that?
Oh, no? Can you see them?
I think so.
Okay.
Let me go. I'm going over. So someone asked, at what age should the last colonoscopy be done? Can you hear me?
Yes.
Oh, that is a great question. That's a great question. And some insurance companies, maybe for whatever reason, they say over a certain age, whether it be 70, 75, or 80, no need for further colonoscopies. I really have a problem with that because people are living longer, they're very active, and then, I'm seeing patients in their 70s, 75, 80, and older who have forgotten surveillance, really. At this point, it's surveillance. So screening is your first colonoscopy. They've stopped doing their surveillance, and they come in with a colon cancer in the prime of their retirement or whatever they're doing, late 70s, late 80s. That they stop screening. So and it's a shame because they should have kept doing their colonoscopy, but not their fault because they were told that they didn't need to. So that answer, again, you'll discuss with your provider. I don't look at age per se. I don't look at chronologic age, 70, 80. I have a lot of patients who are in their 80s that are in better shape than some of my patients in their 50s. So you look at the big picture. What is your physiologic age? Are you active? Are you driving around? Are you enjoying bocce ball? I don't know. Whatever it is you're doing, you're doing a lot of things. People are doing a lot of things and enjoying their retirement and their old age, grandkids, great grandkids. You have to talk to your provider. And really, if you don't, you should advocate for yourself, and which is, if you're here today, you're already doing that. So you don't have to do necessarily a colonoscopy at 70, 75, or 80, but you got to do something. So you can, if your health is not good, your heart's not good, you can't tolerate anesthesia that's required for a colonoscopy, well, then at least do a fecal test or a FIT test or Cologuard or even the virtual colonoscopy. Do something just for maintenance, just to keep yourself well. So my answer is you should keep doing some sort of surveillance, but you have to take into consideration all your situation. I know the question was specifically about colonoscopy. So, if your health is otherwise good, you can keep doing colonoscopy. But if you choose to do a less invasive procedure, it could be at least the stool test or the virtual CAT scan. Oh, did that question disappear? Okay. So I hope that answers your question. So don't just stop doing surveillance because you think you're old, because you're not. If you have one of the risk factors noted and are higher risk, okay, so yeah, if you have one of, the second question, if you have one of the risk factors noted and are at a higher risk, what age should you get your colonoscopy if not 45? That's also a good question. That's where it kind of gets a little fuzzy here. So let's say like I said, your father, let's say maybe a father was, or risk factor as in inflammatory bowel, well, risk factor, well, if you're, let's say risk factors as in Crohn's disease or like ulcerative colitis, if you've been diagnosed with Crohn's disease, you're probably going to get your colonoscopy earlier, like sometimes in your teens or 20s. If you have ulcerative colitis or Crohn's, you're going to have your colonoscopy a lot sooner than 45, and it's probably going to be the reason for your diagnosis of inflammatory bowel disease. So that's the one risk factor. If you have bleeding or any of the symptoms, it again should discuss with your provider. But I've seen colon cancer in as young as someone 18 years old. And as I said, it doesn't mean you have, you go eat at Wawa and you get constipated and you have rectal bleeding, you're an 18-year-old kid, you go get your colonoscopy. I'm not saying that, but you got, if you have ongoing bleeding or persistent bleeding, it's just not going away, well, talk to your provider and say, hey, this is just not stopping. What should I do next? And they may refer you for colonoscopy. So in terms of symptoms, again, bad stuff like cancers, it doesn't go away. Good stuff, bad food, virus, bacteria, winter illness, it comes and goes. Don't ignore a symptom that's just not going away. Talk to somebody about it. So at any age, in that situation, you may need a colonoscopy. Let's see. There was symptoms. Also, yeah. So those are the three categories of risk factors and higher risk that you may consider getting a colonoscopy. Hopefully that answers your question there. Okay. So the next question is, besides doing screening, is there any, it's moving around here, is there anything we can do to prevent it? For example, nutrition or anything else? That's also a really good question too. So what causes colon cancer? We really don't know. What causes colon, it's, there are some inheritable colon cancer genes, but by and large, as I said, the majority of colon cancer cases are sporadic. The feeling is it's something environmental, meaning something in our diet that's causing this, but we can't say what. So can you prevent it? I don't think so, unless you avoid certain things, certain foods, or we don't even know what it is in the food or the water. They've done studies of populations where they move from Europe or Asia to the United States and assume a westernized diet. The colon cancer rates in the people that have migrated over and assumed the westernized diet, their colon cancer rates go up. Yeah, there is some increased risk of colon cancer if you eat a lot of red meat, if you eat low vegetables, don't eat enough fiber, smoking, alcohol. There are little risk factors or modifiable risk factors. You can stop smoking, you can stop drinking, you can decrease your red meat consumption, you can increase your fiber. These are modifiable risk factors that you can do to lessen your chances of getting colon cancer. The ones that are not modifiable are, for example, family history, inflammatory bowel disease, Crohn's, and ulcerative colitis. So, if you cut down your red meat, increase your fiber intake, cut down your alcohol, cut down your smoking, that's you helping yourself. But even if you do all that, even if you were that Olympic athlete in the picture, you still you can't prevent 8. 8, you're going to hit 45 at some point. Even if you minimize all those modifiable risk factors, by virtue of age, you still need to the colonoscopy, and to prevent it is to remove the polyp. But nutrition, yeah, like I said, hopefully that answered your question there. That's a good question. You mentioned colonoscopy is recommended every 7 to 10 years. Should we be doing the occult blood so every so often, or any other screenings while waiting? Yeah, that's a good question. So you're getting a colonoscopy every 7 to 10 years. Should you be doing the occult blood every so often, or other screenings while waiting? Not really. Not really. It's one or the other, because of the sensitivity and the specificity of the colonoscopy. Colonoscopy is supposed to be, very good, very accurate, finding the polyp or the colon cancer. And then remember, the colon polyp cancer sequence it takes place over years. So you're doing what you're supposed to do according to the book. Yeah, your question, second part of your question, couldn't colon cancer happen during those 7 to 10 years? Theoretically, no, based on the slow growth of these. Yeah, I think I hear what you're worried about. Could you have missed something? Sure, you could have missed something. But colon cancer doesn't show up that quickly. I do personally think 10 years is a bit of time, but again, you have to sit and talk with your healthcare provider. Do you have other risk factors to make the colonoscopy more frequent? The 7 to 10 years is in an average risk individual. Now, if in the 7 to 10 years, in you being the average risk, and you have symptoms, change in bowel habit, bleeding, anemia, something's changed. So you don't wait to 7 to 10 years. You say, hey, healthcare provider, I'm on this 7 to 10 year track, but something changed. That may prompt you requiring surveillance at this point a little sooner than the 7 to 10 years. So hopefully, that addresses your question for that. Okay. I think, is that it?
Yeah, I think that's all. Perfect.
Yeah, I think those are great questions. I'm really happy to see these questions and to see that people have attended. As I said earlier, my story with the breast cancer, and at one point women they were very embarrassed to talk about it at the dinner table, because then the numbers came out that breast cancer is affecting and killing so many women. I hope the same would become true for colon cancer. If you could do yourself one favor, you could discuss this topic with friends or family and loved ones, because there is a lot at stake here. It is a common disease. It does kill a lot of people. It is very curable, very preventable. And I'm the last person you want to see as a surgeon, but if you need me, I'd be happy to take care of you. But you really want to be in the ounce of prevention side of that picture, and screening is a way to do that. Thank you.
Perfect.
Any further questions?
I don't think so. I don't see any more. But thank you everyone for joining, and thank you, Dr. Del Rosario, for your presentation today. Again, as I mentioned earlier, a recording of the webinar will be shared with the email address that you registered with, and it will also be uploaded to our Hackensack Meridian Health YouTube channel. Thanks everyone again. We hope to see you at another Women's Health webinar in this series, and I hope you have a great day. Thank you.